Greetings, everyone. Welcome to the 234th session of the online Optom Learning Series, OOLS. And I'm very pleased to welcome back Dr. Shirley Loh for her second session regarding the holistic eye care, which we started a couple of months ago. And she's going to take us through the part two of this session. Dr. Shirley is a clinical optometrist who holds undergraduate and postgraduate qualification from the University of Melbourne. With over 20 years of diverse experience in retail, public health, as well as NGO, and her role in corporate optometry, she has a lot of role to play in helping underprivileged people in the population to see clearly. She's a recognized speaker and an invited guest at the Asia Pacific conferences on a lot of topics which include contact lenses and evidence-based practice. Currently, as a professional education lead for Johnson & Johnson Vision, she has the Southeast Asia, India, Taiwan, and Australia, as well as New Zealand. With that diverse role experience, she is going to take us through the journey about holistic eye care, where she will discuss the next step in her three session series. So welcome, Dr. Shirley, again onto the platform. And, let me just leave the screen time to you, please.
Great. Thank you, Fakrudin, and good afternoon, good evening to everyone who's joined us today. And it's my pleasure to be hosting this webinar with you. It's really something I'm passionate about, and I'm glad to continue the second session. And today's session is about maintaining lifelong vision with holistic eye care. And we're covering the topics of glaucoma, AMD, and dry eye. So we're really going to dive deep today, perhaps deeper into the research than you ever have. But I think as practitioners, that's a really good point to start with. We should keep expanding our knowledge. And I've found being able to research this topic very helpful just for myself, just to understand how I would like to prevent these diseases and conditions for myself and my family and my loved ones. And if we can even extend that to our patients, even better. So first of all, I'd like to thank the Online Optometry Learning Series and Fakrudin for the opportunity to speak to you all today. So for those of you who did join last time, this series covers something that's very dear to my heart, which is really about, healthy vision. And let's go back one step and remember, what does healthy vision actually enable you to do? Well, it's everything that we want to do in life, almost everything that we enjoy about life, where we can excel at work or have fun with friends and family or go on vacations and do physical activities with. This all requires eyesight, of course, and it's one of those things that we do take for granted until things go wrong. And this is why this whole series is very much on the key of prevention, to make sure these things don't happen in the first place, but to take a very proactive stance, a very knowledgeable stance on what we do from day to day and our recommendations for our patients. So let's moving on. Again, if you hadn't joined the last session, I just wanted to do a quick introduction. Thanks, Fakrudin, for sharing a little bit about my role. So I have been involved in training and continuing professional development, and I also get involved in public education and advocacy, which I think is really important. I actually did begin my career in Australia in retail optometry, and then I did work for a number of years in the Australian Optometry Association, where I really did learn how it's so important to bring together different parties, bring together the government, the associations, and the professionals so we can work together. And alongside this, I realized partnerships in raising professional standards is something that we can all play a part in. It's not just up to big organizations to do this. Every single one of us can do this. And you all being with me here tonight is your step and your involvement in being part of this big movement that will continue. And so, whether it's just seeing individual patients or reaching out and touching lives in a different way through education, that's something that I've enjoyed doing throughout these last couple of decades. So moving on, I'm just doing a quick recap of last time. So when it comes to good eyes, maintaining lifelong vision, it's as simple as look good, see good, feel good, okay? And that's fairly straightforward. I think everyone can agree with this. But when it comes to eyes, this is very true, but then it's always linked with our systemic health as well. So our whole body has to look great, feel great, and perform great. And of course, the two gel. And of course, the eyes are indeed a part of the body anyhow. So as practitioners, what do we need to know? What are the nuances that bring us together? And what do we actually need to understand and share with our patients? So in the last webinar, again, it's been a while, so I just wanted to cover that there are circumstances where it's possible, and we did cover these and we shared some responses last time, but there are times where the eyes can feel fine, but they see poorly. And of course, glaucoma is what we'll cover today, and AMD, one of those things. See well, but the eyes feel terrible. You know, there are conditions like this, and have great visual acuity, but poor vision. So, for example, just really a lot of uncorrected vision out there, and surprisingly it does exist, and we do find it in the many screenings that I'm participating in. I'm not sure if anyone in the audience has participated in community screenings, but it's surprising how much of the population actually do go around uncorrected or undercorrected. So holistic eye care really is getting the perfect match of a healthy, optimized, knowledgeable patient meeting with a healthy, optimized, knowledgeable ECP like yourselves. And this is the interaction that we want to create. So again, in the big picture, I'm just going to take a step back and really talk about, as practitioners, we want to say the correct thing to our patients. We want to make sure that we're not exaggerating, we're not overselling, but we're not sort of being very cursory either, and just, you know, not really telling patients how important and how dire their situation may be if they don't take care of their eyes in a certain way. And for this, we have to have a very good sense of the current evidence. And as I am researching the many different topics, I realized that as a practitioner, you have to put your researcher hat on sometimes. And as a scientist, for anything to be really considered truly evidence, we have to think about the mechanism. So do we know at a cellular level, at a biochemical level, or a physiological level, why things are happening, and why could certain interventions help, and perhaps what is actually going on to help or even hinder a particular condition? And then we have the notions of association and causation. So sometimes it happens to be that, you know, certain populations that do a certain thing or behave a certain way seem to have more of this condition or less of this condition. And sometimes we know the causation itself. We can actually marry the association and mechanism. We know that there's a direct cause. Now, sometimes as practitioners, I'm going to challenge you all tonight that in the case of eye care, in these diseases like glaucoma, AMD, and dry eye, we do know a lot, but there's a lot that we don't know as well. And sometimes, you know, we don't fully know the mechanism, but we definitely see sort of some associations. And so this is where, as a practitioner, sometimes we have to take that leap of faith. We have to ask ourselves, is there enough knowledge about what I can recommend, even though it's not purely and, you know, widely recognized as the default treatment, but perhaps there's something I could recommend to my patients, tell them that it could be helpful or beneficial for them. And we also have to consider what are the downsides of making those recommendations. And as I go through the different recommendations tonight, I think you'll see that in many cases, there's not many downsides to preventative eye care, but a whole lot of potential benefits. And this is something that I hope that you can start to embody yourself and also begin to share more confidently with your patients. So let's keep this in mind. I'll be covering things like the mechanism, association, and causation today as we talk about the evidence. Okay, so I'm going to kickstart with glaucoma prevention. So glaucoma is a very, very common condition. So I'm just going to I'm going to get some interaction here from the audience. So if we can actually do a poll, and we can do this by putting A, B, C, or D in the comments. So this was a particular study here from 2022, so not too long ago. And in the introduction that says glaucoma is the something leading cause of blindness and the first leading cause of irreversible blindness, affecting more than something million people. So in the chat, I would encourage you to write A, B, C, or D. What do you think it is? A few C's. There was a few C's? Okay, C's coming up very strongly now. I'm not sure if so someone suggested B. Yeah, but majority is C. Maybe there was adequate time to Google it or use ChatGPT to find the answer. But if not, that's okay. And I think it's important for us, again, as eye care professionals to know how very prevalent these conditions are. But yes, indeed, it is the second leading cause of blindness and the first leading cause of irreversible blindness, affecting more than 80 million people worldwide. So definitely, something that should be on our minds as eye care professionals, as primary eye care professionals. So let me just go through. So in this particular study, they're looking at potentially, is there an opportunity to repurpose antihypertensive drugs for prevention of glaucoma? So let me just explain. So in the introduction, it talks about the current treatments for glaucoma still focus on reducing intraocular pressure, but glaucoma is a multifactorial disease, and the single treatment approach delays the treatment of other glaucoma patients with non-high IOP, so such as normal tension and low tension glaucoma. It's very difficult to treat these patients because the mainstay treatment is to lower pressure, and if they already have low pressure, where do you go from there? So the question is there something else we can do to potentially help these patients? So several antihypertensive drugs, such as beta blockers, these angiotensin converting enzyme inhibitors, and calcium channel blockers, all very common sort of systemic drugs that a lot of the elderly use, have been used to treat glaucoma. Doctors who take this view of the medication believe that high blood pressure may impair the blood supply to the optic nerve, and therefore the capillary pressure of the ciliary body caused by blood pressure will increase IOP. So I'm going to go to another poll again. Do you think, does systemic hypertension have an effect on glaucoma? Yes, a significant effect. Yes, but not clinically significant. No, and not sure. So, it'll be interesting to see a significant. Okay. What do people think A? So thank you for your opinions. It's good to have a guess anyway, even if you don't know. Okay. All right. So let's have a look at some of the data there. It looks like A is the most popular choice. So first of all, I'm just going to go through exactly how they investigated these causal associations of glaucoma. So in the study, they investigated the genetic correlation and causal association of several things. So first of all, IOP, systolic blood pressure, which is SBP, diastolic blood pressure, which is DBP, and 12 antihypertensive drugs. And so it was actually, quite a large study, as you can see, and they actually sort of separated all the patients into different groups about, where they belonged. And in this case, they also looked at genomes, and they actually looked at data from 500,000 volunteers aged 40 to 69 in the UK. So, I think, again, when we're looking at evidence, we recall that having the larger group involved is actually really important because it gives statistical significance to the findings. So the glaucoma cases were defined as self-reported glaucoma status in response to the question, has a doctor told you that you have any of the following problems with your eyes? And the control group included non-cases and excluded subjects who reported prefer not to answer. So it's quite a big subset here. So interestingly, the results were that antihypertensive drugs neither treated nor worsened glaucoma. And so you can see here in the conclusions that together controlling blood pressure may not help prevent and treat glaucoma, and antihypertensive drugs may neither treat nor worsen glaucoma. So it should not be used as an intervention for patients with glaucoma. So there's no obvious sort of relationship there. But interestingly, as I read through this article and I look at the details, there was actually, it pointed out another study. And in another study, it actually said that Chong, does this other investigator called Chong actually investigated the correlation between different types of antihypertensive drugs and the thickness of the retinal nerve fiber layer. And they found actually in Asian populations that the antihypertensive drugs might damage the health of the retinal ganglion cells. So I went on to actually explore this other article. So, but wait, can antihypertensive drugs actually contribute to glaucoma? So this is another thing that was investigated. So again, quite a well-done study, because as you can see here, it's actually done in an Asian population, I think, which is quite relevant here for our audience tonight. And we can see how it studied 9,144 eyes at the retinal nerve fiber layer. You can see quite a mix of cultures here, Malay, Indian, Chinese. And they underwent systemic and ocular examinations. They were interviewed, they had the IOP checked, they had tonometry, they also had fundoscopy and OCT and blood pressure. So you can see it was very, very, I'm sure it took a lot of time to complete. And so, yeah, so just to explain, there was definitely a damage that was seen and thinning of the retinal ganglion cells, which could potentially then contribute to glaucoma. So going back to our sort of association and causation and mechanism. So in this case, this study more looked at the mechanism, because we know that the retinal ganglion layer is actually a really important part of the integrity of the retina itself. But it didn't go on to then see if there was an actual association or causation after that. But definitely it sort of established that there would possibly be a mechanism here to consider. So my take on this actually is the antihypertensive drugs. If we can actually, they could be potentially harmful or contribute to glaucoma, and they certainly don't seem to benefit glaucoma. So my interpretation of this sort of latest research and, what is in the literature is that ideally, actually, we should be trying to avoid the antihypertensive drugs if possible. So I've got this other study here, which is about, now it's called beta blockers in dermatology, but it actually highlights some really important factors for us, that these are the potential side effects of beta blockers, which are used for antihypertensive cases. So you can actually see that they can rarely, but sometimes cause these dry eyes and visual disturbances. But interestingly, there are beta blocker receptors in the ocular tissues. So you can see here that the beta blocker receptors, the beta 2 receptors are actually involved in outflow and secretion of aqueous humor. So we realize that whenever a person is taking systemic drugs, they're going all over the body. And depending on where the receptors are and which tissues and organs those receptors are, that drug has the potential to affect. And maybe this has some way to result in the other previous study, which was saying that there seems to be like a thinning of the retinal fiber layer in patients using antihypertensive drugs. Okay, so from that, I also wanted to highlight, the short and long-term side effects of beta blockers. So, it's not a great story, right? So these drugs can cause bradycardia and hypotension, two effects that may commonly occur. So remember, these drugs are meant to treat high blood pressure. So if the dose isn't right, if it's a bit too strong, it can cause the opposite. It can actually cause hypotension, which is low blood pressure, which can result in fatigue, dizziness, nausea, and constipation, and other dysfunctions, and less commonly bronchospasms for these particular drugs. They actually just overall can contribute to a feeling of fatigue. And some of the long-term side effects of the beta blockers can include disorientation, short-term memory loss, emotional changes like mood, inability to concentrate or think clearly, and decreased performance on neuropsychological tests, which is difficult, right, to understand, especially since these drugs are given to older people usually. So, are they just getting elderly? Do they just act this way? Are they slowly changing? Or is it something to do with medication? And this is where it becomes very, very difficult to know, if the drug is actually helpful or is it harmful for the patient, and what is the cost to benefit ratio there. Other side effects of beta blockers that have come up, again, the range is huge, from weight gain to edema, which is the swelling, to cough, and again, these are things that elderly sometimes display, but are they, is it just because they would naturally get this anyway, or is the drug that they're taking actually making them worse? This is the question. And of course, it's not our job to actually be in control of prescribing or deprescribing medications, but in any case, it's good to be aware of these things, if at least for ourselves, knowing how to take care of our own health as we get older, and again, the people around you. But you could probably, again, come to the conclusion that if we can stay away from these drugs, then that would be better for all of us involved. Understanding that the initial prescription of these drugs is for the high blood pressure in the first place. If there's other natural ways to reduce that, potentially that could be the case. Okay, and both selective and non-selective beta blockers do have symptoms. So I think sometimes people believe that the more modern drugs have less symptoms, and these are called the selective beta blockers, are the more modern versions of the drug, but in any case, they still cause a wide variety of dizziness, tiredness, weakness, etc. And the reason I'm bringing this up, and perhaps some of you in the audience, I think around about our age, probably have elderly parents at this stage. So some of your parents may be on these medications. And again, certainly many of our patients are on these medications as well. I wanted to highlight my own dad actually is on these drugs. And this year he's been in and out of hospital quite a bit with this edema. So edema is the swelling. So there's a very, very fine balance of being able to obviously have this medication that he has been on for a few months. But on the other hand, it does affect his fluid balance in his body, so much to the point where he's so swollen, he's had to be admitted several times, all the way from his head all the way to his feet. And then they have to give another drug that sort of expels the water. And the second drug they give is actually affecting his kidney function. So it is kind of it's a domino effect. And like I said, it's not up to us to stop or start systemic medications, but, being aware of the many implications that this has on both the physiological display of symptoms both ocular and systemic, but also the behavioral changes as well. So prior to these episodes of swelling, etc., my father did have like long episodes of coughing, constipation, diarrhea, and things like that. So again, is it just because he would be experiencing this anyway, or is it because of the medication? In reality, it's probably somewhere a bit of both, and we could probably never really tell because this is an N equals 1. So with glaucoma, the early detection is currently the only proven preventative measure. So going back to what I was saying before about evidence, when it comes to understanding what it takes to give a very clear and undivided viewpoint for your patient, whether it's to take something or not take something, it's still fairly unclear. The jury's out in the scientific research right now. But there's one thing that we can obviously do, and this is, screening. And so the question has been raised in many countries, should we actually screen? And this was one particular study that showed that in this particular study, there was 682 individuals. And in that group, it was actually found, I believe there were 83 patients with high IOP. So 83 patients out of 682 that were screened. I think you could say, that was a fairly high hit rate, right? Obviously those people would then have to have further investigations if they have, actual glaucoma or just high IOPs or, some other factor that's affecting the IOP for the day. So, potentially this is something that governments have to really consider. But as ECPs, we have the ability to make that decision and go ahead and screen the patients that are in our rooms. So can I also have a question to the audience? How many actually screen or check IOP routinely for people who are over 40? So we'll put a Y for yes if you do this routinely. I'll be interesting to, and if you don't, understand maybe some places we don't have the gear, the equipment, etc., or it's not common practice in your countries. So let's have a look here. Yes, we do have some yeses. And I would encourage anyone who currently doesn't do this routinely for their over 40-year-old patients that they can invest in their own equipment, right? Sometimes our practices don't necessarily have all the equipment that we want as the practitioner, but as we know, there's a number of sort of portable devices now that are pretty good at measuring IOP, and we can use those. Okay, so what else was in the literature? Okay, so this was an expansion of the study that I was just mentioning, that they actually did this over several years from 2012 all the way to 2015. And as I mentioned, a fair few of them had high IOP and also large cupping. So these are definitely things that we can look for in the consultation room. And this is yet another study that's looking at glaucoma, and it says here that vision loss from glaucoma can be minimized by recognizing systemic conditions and medications that increase a patient's risk of glaucoma and referring high-risk patients for a better and thorough examination. So we should be asking those questions about systemic conditions because they're potentially also taking drugs for those systemic conditions, which may have an effect on their ocular health as well. And of course, they should be then monitored very carefully to see if they need any interventions like surgical treatments or any eye drops as well. So I just wanted to highlight here that this is actually, the list of medications that my father is on, and he has to take every single day. So as we go through this next part of the talk, I'll actually share with you some of the sort of other supplements and interventions that are lifestyle interventions that can be recommended. And, it dawns as interesting that as we get older, almost everyone that I know who's over a certain age is actually on this long list of various medications. And I believe that it's something that, that in the future we may consider that, if there are other ways to not get onto these medications in the first place, the better. People have somehow they have an aversion to things like natural supplements, especially earlier in life. But by the time they get older, they have all these sort of problems that then need medication. And, they're prescribed these things. We don't necessarily even ask about the side effects when we prescribe these things. And yet, we have this acceptance that this is the way things have to be. So I would like to suggest that there's a more proactive way of doing things, that we can potentially think about what could we be doing earlier. And, even if we don't have that complete picture of mechanism, causation, and association yet, would you be willing to maybe take those preventative measures to not have to be in this situation when you're older, or again, when your patients or loved ones are older? Okay, there was another question whether this particular drug called dorzolamide could prevent primary open-angle glaucoma. So this, again, was a pretty large study, 1,000 patients, was put on this potential drug that they thought could help prevent glaucoma or help to treat the pressure. And so, in fact, there was none. So I'll just point out here the findings. The overall IOP reduction of dorzolamide was 15 to 22%. However, a clinically significant and a meaningful placebo effect in lowering IOP has not been observed. So there was a difference, but it wasn't clinically significant. So at this stage, they failed to show a significant protective effect of this medical therapy as compared to placebo at this stage, so in this particular study. And so the jury's still out. There's nothing sort of that we can do. So as I mentioned earlier, there's no potential sort of systemic drugs that we can provide at the moment that could help prevent glaucoma. But what can is awareness. I just wanted to point out this case study actually that I happened to be involved with. So when I was working for the Optometrist Association, I also practiced part-time as an optometrist, and I also had quite a few years in retail optometry. And this was a very memorable case because this particular man, Mr. Robert Chong, was from Malaysia, and he came to Australia. And although his family arrived with not much in Australia, he quickly gained, an education, and he actually became the mayor of one of the regions in Australia. And he actually came in to my practice one day, and he was one of my patients. And this article is really raising awareness among Australians, and in this particular community with Asian Australians too. But it was the quote here that he used to practice like kung fu with his father, and he remembers his father saying, don't get into any fights when you get to Australia. But now he's in a fight with glaucoma. And so what happened was 5 years ago, during a regular checkup with his optometrist, which was myself at the time, he was diagnosed with glaucoma. So I did check his, pressure. It was high, and also his optic nerve, the cupping was already quite significant, to be honest. And so, he was diagnosed early-ish. He hadn't had that much, visual dropout yet. But like I said, to be honest, he from my clinical point of view, his cupping was quite significant. It leads me to think that, you know, all the previous eye checks he'd gone to before had anyone even checked, because for me it was, you know, it was so obvious. But luckily he hadn't had the visual dropout yet, and the message in this article that, you know, was on the internet, and the government put this out, was that he got to minimize his vision loss and he can, you know, have his treatment interventions earlier. This is what he continues to do, and just having that awareness. So, you know, if there's anything you can think of as a practitioner where you can raise awareness in your community, on your Facebook, you know, share a case even without the name if you can, things like that, it just keeps the conversation going. There's another association that is about glaucoma, and they actually do publish research updates that are upcoming novel treatments that could potentially treat or reduce the incidence of glaucoma. And this is actually looking at nitric oxide. So there's a lot of interest in nitric oxide as something to help with the sort of the blood and the blood vessels. So it turns out that nitric oxide can potentially work as this glaucoma treatment. So it's currently being researched, and some of you may know actually that its popular form is from the food of beetroot juice, because it does help with blood flow and lower blood pressure. So that's something that's in the making. And there's also even novel research into what they call synergistic prodrugs of N-acetylcarnosine lubricant eye drops and mitochondria-targeted antioxidants act as a powerful therapeutic platform for treatment of cataracts and primary open-angle glaucoma. So, you know, this whole theory of, you know, antioxidants and treating or potentially preventing these eye conditions is something that is being heavily researched right now. So, and by the way, if you have any questions, please feel free to put them in the chat. Otherwise, I will keep going here. So we do see a bit of pattern. This is a sort of a summary of this section about glaucoma, that I'll just sort of reiterate again that the current treatment options revolves around controlling IOP. And as I said, there's limited capacity then to treat normal tension, and especially in many early cases that perhaps the IOP is not that high yet. So there are several pharmaceutical agents that have failed to demonstrate efficacy for glaucoma treatment or prevention. So they keep trying to look for different ones. So far, the ones around antihypertensive don't really work. In fact, they may even make glaucoma worse. And do keep in mind that all pharmaceutical drugs have side effects. And also, as I was sharing, that comprehensive clinical and genetic screening may enable earlier treatment intervention. So asking your patients if their, you know, parents or relatives, you know, close relatives had glaucoma, you know, or any family history of eye conditions, I think we can keep that open. Really, really make sure we always ask that question in our history taking. And it is, you know, a bit of a funnel in terms of when we're looking at the state of general health and what the comorbidities may be. And obviously, if we're having things like high blood pressure, then we're going to have to take drugs, pharmaceutical drugs. And, you know, some of these patients will have glaucoma too. So, you know, obviously, if we can bypass these things, you know, certainly some people with good general health still do glaucoma, but they won't have these other co-founding factors and potentially destructive factors that, you know, the drugs can cause on top of that. So, you know, can we skip this part? And, you know, and if we're still unlucky, we would, you know, potentially still have glaucoma, but not have the other problems that could be associated. So I'm going to move on to AMD prevention. Okay, so there's a lot of research around prevention of age-related macular degeneration, and, you know, it definitely compromises quality of life. And a lot of you have heard about AREDS, the AREDS study 1 and 2, looking at certain antioxidants in a selected group of patients. But I wanted to go in a bit more detail today to share with you perhaps, some facts and figures so that we can get into our minds, what was actually researched and what, again, we should be recommending to our patients. So interestingly, there's also been research asking, do ECPs recommend supplements and lifestyle changes? So we remember that glaucoma is the leading cause of irreversible blindness. Well, age-related macular degeneration is a leading cause of visual loss in those over 65 years of age in the industrialized world. I think in another study, it actually said that in the US, 11% of people have AMD, which I thought was quite very high. But, again, it's very, very common. So this question was actually asking what were ECP's behavior when it comes to discussing with patients. So it's just interesting. So 39% of these ophthalmologists actually recommend 2 out of the 4 interventions. So there's several things that we can actually say to our patient, which is smoking cessation, antioxidant use, Mediterranean diet, which is like a healthy diet, lots of fruit, vegetables, omega-3s, and maintaining a normal BMI. And 22% actually recommended all 4 interventions. So I think there's a question you can ask yourself, is this something that you recommend? Are you actually talking to your patients about these kinds of things? And do you mention one or all of them? And, again, to be able to stand out from the rest, perhaps we can really take our time to go through exactly what we're recommending and why. Okay, and let's go into why should we recommend these things. So as we know that AMD, it's a leading cause of blindness, and still there's no effective treatment for geographical atrophy. And therefore, the most effective management of AMD, again, is to start with prevention. So we know we're just going to look here at these things with the AREDS formula, omega-3 fatty acids and berry extracts and lifestyle modifications, and also filtering sunlight and blue blocking intraocular lenses, and see what the research says about those things. Okay, so this was a table from that study. And this is just to remind ourselves of the categories of AMD. So AMD can be called category 1 to 4. And so when we start to see small drusen on the eyes, the visual acuity can be 20/32 or better. This is category 1. So this is when we start to just see the appearance of small drusen on the eyes. Category 2 is mild to borderline, and these are multiple or intermediate drusen in one or both eyes. But still, the vision is still not too bad. Category 3 is called when we have pigment abnormalities in one or both eyes. When we start to see pigment changes as well as the drusen, we could also see some intermediate, larger size drusen and geographical atrophy. And this is still not affecting vision. And category 4 is advanced AMD. So these are the 4 ones, which is when you get really the geographical atrophy. Now, let me move on to the supplements. So these are the supplements actually that were researched in the AREDS study are significantly higher than the dosages found in food. So, some of us think, oh, maybe I can get all of my sort of nutrients from food. So this was actually the formulation in the AREDS study, which is, you can see, vitamin A, 5,000, vitamin C, 500, vitamin E, 400, zinc, 80, copper, 2. And you can actually see, for example, when it comes to something like vitamin C, even an orange, you would have 53. So you'd need like 10 oranges to come up with the same dosage that you would get in the supplement that was used in AGREDS, etc. So you can see, for example, some of these, it's almost impossible to get this same level of, dosages from food alone when you want to be able to treat something at a very clinical level. Okay. But that said, that a healthy Mediterranean style diet, which has a lot of fruit, vegetables, and omega-3s, actually can reduce the incidence of AMD by 35%. So, it's a consideration when it comes to how consistent the person can be in their eating. So, is someone going to really be very vigilant in making sure they have that range of vitamins and mineral-rich diet every single day? If there are someone who, if you have patients who are very, very consistent and they're having a good lifestyle, but if someone was already having some of those factors, thinking about back to the categories that we shared earlier, even if they have, say, category 1, but that their diet isn't very good and that they're not going to change their lifestyle, it is a consideration then to recommend something like a supplement for them. Okay. On the other hand, omega-3s may need more research. So the reason why they did study omega-3 is that they do help reduce the incidence of cardiovascular diseases and strokes. And so there may be a thought that it's significantly helpful for blood vessels, which is why they considered it for AMD as well. But so recently its role in AMD has been investigated. And as we know, there is a concentration of the photoreceptor segment in the retina. So these DHAs are really important for our vision. And our vision is a very dynamic process, right? It's actually using up and it's being shed and reformed in a normal cycle. And it has been shown to reduce inflammation and regulate autoimmune responses, which in turn helps prevent AMD. But the research so far in the meta-analyses is not confirmed and not consistent. So ongoing larger trials are needed for this. So back to what I shared at the start, this actually shows the mechanism for why omega-3 may be helpful. We know that the substance of DHA, which is a part of omega-3. So just, to reorient you, if you haven't remembered this before, that omega-3s consist of DHA and EPA. But in the case of eyes, it's the DHA, for the retina anyway, that is helpful because this is used in this part of this anti-inflammatory cycle that happens, and it's part of our vision. So they've established a mechanism, but throughout the meta-analysis, we haven't actually seen that association too strongly yet. But again, there are many benefits, cardiovascular benefits for omega-3. So the cost to benefit ratio can be considered. Do we, as practitioners, wait till the very end, to wait for this, meta-analysis to come up with something that shows us that it is helpful, or do we just work on the mechanism first? We know that potentially there's, helpful in our retinal cells. So perhaps that is enough then to recommend to our patients. This summarizes some of the current evidence. So the strength is, 1 is highest. So the AREDs actually talk about a regular intake may reduce the risk of neovascular AMD. So this is actually talking about preventing the dry going into the wet AMD. And so this, the strength of the recommendation is actually strong as well. But you can see here for the others, for things like the omega-3s and the lutein zeaxanthin is still what we call a category 2, in which case the recommendation rating is a C. So it's not as high at the moment. Mhm. So this is that summary there. Okay. It's also something to keep in mind that fish oils, omega-3s, actually have potential to thin blood. So if the patient is already on something like warfarin or aspirin, then perhaps we do not necessarily have to recommend fish oil, or just be aware, that it can increase the blood flow and bleeding. And again, when we are doing our history taking for our patients, we should be asking them what current medications they are taking. And sometimes you may be the practitioner to join the dots. So I recall one of my friends, who's also an ECP, actually had a patient who constantly had this conjunctival bleeding, so epiconjunctival, hemorrhage, and which we know is not very dangerous, but it's actually just not very pleasant, of course, and it doesn't look very good. And nobody could work out why she was having these so regularly. And then finally, her optometrist realized that she's taking blood thinners as well as, the fish oil, and this was enough to cause this symptom in her. But then again, that's something that could be discussed and then treated or reconsidered by the GP as well. Okay. Now, in this other part, in the ARED study, they actually looked at BMI as well. And a higher risk of geographical atrophy came when AMD was seen in subjects with higher BMI. So the odds ratio was 1.93. So it's, almost double in obese individuals, which are greater than 30 kilograms per meter, compared to normal people. So, BMI is definitely something that could be controlled. So when we're talking about controllable factors, we're talking about things like smoking, diet, and this is BMI. So, dawns upon me, is it our place as eye care professionals to talk to patients who are clearly obese or overweight, and when it comes to their risk profile for eye diseases? Again, it depends on how comfortable you are with having these conversations, but I think, it's the way that we have the conversation to start with, that we do take a very thorough history to begin with, especially including their family history and things like that, their medications, and to actually then share the data. So as a practitioner, you can take, a less personal approach. We don't want to be offending the patients or anything like that, but we can just let them know that, in research, it was shown that, the increase of AMD can be significantly more, even almost double, if the weight is not well controlled. So it's just something for the patient to consider. Okay, and the last thing that was researched was reducing light exposure and using sunglasses, blue blocking, and things like that. So there was this Beaver Dam eye study, looked at over 2,700 patients in a 10-year period, and it found that extended sunlight exposure was associated with higher incidence of AMD, but somehow the protective effect of sunglasses was minimal. So again, in this case, we don't fully understand the mechanism. But then again, it does depend on the patient's recollection of how often they wore their sunglasses and things like that, which, is always fraught with inconsistencies. So another thing that can be considered, which is easier to study because it is consistent, which is using intraocular lenses with either ultraviolet or blue blocking capacity. And this means that this can actually be studied as well. So what did it actually find? That conventional IOLs actually theoretically protect the macula from phototoxicity. It's, again, the mechanism is there, but the association or causation is not thoroughly established yet. But I wanted to highlight, the differences in natural versus artificial lights that we come across. So, what's the difference between natural and artificial lights? Well, I've actually got a cross-section here of the spectral distribution of sunlight and what a laptop could provide. So these are like digital devices and things like that. So we actually do get a significant blue spike from artificial sources. And just to highlight, some of us may think that the sunlight actually has a high amount of blue. In fact, without atmospheric absorption, it would. But as we get closer to sea level, the spectrum of sunlight actually evens out fairly evenly across the visible spectrum. So you can see here, this is actually a 3D imaging of what the spectral distribution would be like for, you can see here in a time course of sunlight in Tokyo. So again, in Asia, and it's fairly consistent across our part of the world. And you can actually see this cross section here. It's actually very similar to the one that I showed earlier, where there's a fairly even distribution of the different colors of the spectrum. Whereas in artificial sources, there's this significant spike in blue. So it's something that our eyes probably were not evolved for, I would say, and we do look at a lot of digital devices these days. Another thing to consider is that, depending on the direction of the sun at different times of day, that changes, whereas with artificial sources of light, we are getting that, in a way that our eyes had not been evolved for. So as I'm looking at the laptop for many hours today and every other day, I'm becoming more aware of what this could do for my eyes. So in this review paper, I actually looked at how blue light might affect mental and behavioral disorders. So I'm just going to share some of the results. So actually this particular study looked at nearly 5,000 patients, 1,700 males, 3,200 females. And it actually looked at, so I just extracted the ones that were about mood and behavioral disorders. So we have, for example, major depressive disorders. We had 80 cases among that group, and fairly, even between the blue light filtering and non-blue light filtering IOLs groups. So keep in mind that these are patients that had the IOL inserted. So we know that for sure that they're looking through the blue light filter or not. So interestingly, so other anxiety disorders, we have 21 in the blue light filtering and 33 in the non-blue light filtering. Sleep disorders due to known physiological causes. Again, we do have less in the blue light filtering than the non-blue light filtering. Keep in mind, though, that the p-values were not significant. So the only clinically significant p-value was actually the sleep disorders. So in this group of subjects, 145 had a sleep disorder. We have 54 in the blue light filtering and 91 in the non-blue light filtering. And this was the only so-called statistically significant value. And just, again, out of interest, there was 9 cases of migraine, 1 in the blue light filtering and 8 in the non-blue light filtering. So it does, lead to the question of, is there some kind of effect when it comes to, behavior and mood in blue light? Maybe it's not helping, it's not absolutely proving to support with the AMD yet, but perhaps it could help with mood and things like that. I thought this study was also interesting because now this was done on mice, but they actually used different blue blocking lenses on the mice, and you can actually, let me just explain what this means, that this is the level of social interaction the mice had. And even though it's not a huge difference, you can actually see that those with the long wavelength enriched, so they're not blue, the blue blocking, because they've got more of the long wavelength. And you can see here short wavelength, they have more blue light. They actually, for some reason, have less social interactions than the ones that had the blue blocking. So they're less social, which could potentially mean they're not as happy. And they also had less changes in their grooming as well. So anyway, interesting because with these mice, they didn't change anything else but, the lenses that they were looking through. So, and it did seem to affect their behavior. Okay, so now the associations between systemic medications and development of wet-related macular degeneration. So this was a retrospective study. You can see here in a very, very large cohort of patients. And the association between use of systemic medication covering 85 different drugs were considered. And, going forward. So of the different, there are several different drugs that were actually found, and this report covered some of them, but one of them was a calcium channel blocker, amlodipine, and this is a very common drug that is used, again, in the elderly, and it works by affecting the movement of calcium into the blood vessels. But this one did have a significant association with wet AMD. So I think, we could actually consider here that the blood vessels are actually, the health of the blood vessels is linked to all different parts of our body, including the use of our eyes and eye diseases. And this is definitely something that, we should keep in mind when it comes to, our systemic drugs used to treat big blood vessel conditions are going to affect the eyes as well. And so we do have to be mindful of these potential interactions that can happen. So similar again, with AMD. So let me just summarize in these key points. So there are specific antioxidant formulations have been shown to be effective against AMD. Mediterranean diet and controlling BMI may also have preventative effects. The high energy blue blocking may be beneficial and also confer behavioral and mood advantages. AMD preventative measures have no significant downside. So if you, can control your BMI and have a good diet, of course, that can't be too bad, right? So, similar, I guess, when it comes to glaucoma, when it comes to AMD, we have some interesting associations here that we should be considering for our patients. And again, if we can prevent those comorbidities, then the value and the happiness of life will be better. Okay, so now I'm going to go into dry eye prevention, which again is very, very common among not just the elderly actually, but many, many different people of all ages. So I think for those of you who've not seen the universal stress model before, that I'll just cover this, that all biological systems actually go through these cycles of stress and recovery. And what we do in the biological system is maintain a state of homeostasis. So we try and, balance the body again. And certain stresses actually can increase performance capacity. So when we're talking about something like exercise, that's a stress on the body, but it actually helps to increase the level of homeostasis, so we actually improve our capacity. But in the ocular system, stressing the eyes, especially when it comes to dry eye, exposing them to more dry conditions is actually not going to help in this circumstance. And dry eye, is it the new epidemic? It's very, very common. I'm sure some of you are becoming aware that especially in Asian populations, there's definitely research to suggest that tear breakup time is lower in Asian populations. So in the past, 10 seconds used to be the cutoff for a normal, but it's been shown in evidence that in Asian populations, 7 seconds is actually may potentially be a better cutoff because, the prevalence of it. And recently in this study, which is looking at dry eye, they believe there's an explosion of the use of digital devices and shifts in diet and other contributing factors. So we're going to be encountering an epidemic of dry eye. certainly in some of the practical workshops I've been running in Asia Pacific, and we just get members of the audience to look at their eyes, it's surprising how common dry eye really is. Okay, so, things like stress and whether it's chronic or acute can actually make things a lot worse. So things like digital devices, long hours, stresses like deadlines and using multiple devices, poor ergonomics actually increases that potential to feel the dry eyes. Whereas obviously if we can aim towards more adequate sleep, ergonomics, have good balanced hormones, diet, exercise, movement, that will definitely help reduce that feeling of dry eyes. But a lot of us are pretty guilty, I think, of not doing those very well, especially getting enough sleep. So what else? The research actually shows that that people are spending more time on digital screens. 9 hours is the average time spent on any digital device worldwide. And while we look at digital devices, we blink around about 60% less during that time. So what does that, also it can be affected by age, sex, ethnicity, ocular disease, for example, meibomian gland dysfunction, systemic diseases. I think I mentioned earlier something like the beta blockers affecting and potentially causing dry eyes, environmental pollution and air conditioning, all these kinds of things can be contributing factors as well. So let me just move through this, that, with certain contact lenses as well, we have to consider pervaporation, and this is movement of moisture through the lens. So depending on, some lenses can actually hold on to the moisture better, and some actually the moisture is actually leaving the lens. And where does the moisture actually come from? Of course, it originally comes from the eye, from the tear film itself. Right, so from its initial packing solution, it will be placed on the eye, but then the tear film will be impregnated into the substance of the contact lens. So this is, a consideration for our patients as well. And there's actually a vicious cycle when it comes to dry eye disease and digital devices. So let me just explain. So this is a particular, reference here from 2022, but they realized that when we're looking at digital devices, as I mentioned, we have a decreased blink rate. So we blink less often, and this decreases our tear breakup time. There's also potential for increased incomplete blinks, especially if we're very fixated on whatever it is we're looking at in the screen. And it can be just common among people, depending on their anatomy as well. So tear film instability leads to excessive evaporation, and that leads to hyperosmolarity, meaning there's a higher concentration of salts in the eyes, which encourages inflammation, which then damages the ocular surface, which can then damage the goblet cells. So you remember the goblet cells are located in the conjunctiva. So if the conjunctiva gets damaged, the goblet cells can fall out. There'll be a dropout of those as well. And mucin loss, because that's what the goblet cells produce, which can then even further cause more tear film instability. So you can see dry eye, once it gets started, it can be quite a vicious cycle that happens in the eye surface. I also wanted to point out that the effect of hormones on eye diseases actually is something that we should be considering as well, which kind of explains, why changes in female hormones, for example, affect dry eye, and why dry eye is very common among the, above 40 female age group. So you can actually see here, for example, that estrogen and progesterone have a role, for example, in inducing, so suppressing the inflammation, and this is also helping to upregulate pro-inflammatory cytokines. So there is a role in the way hormones play out in the eyes. So we think of hormones, especially female hormones, in the case of reproductive cycles, but they, again, have a role elsewhere in the body, depending on where their receptors are. And there's definitely some in and around the ocular tissues. So here's an example of how thyroid hormone can also affect the tear breakup time. So hypothyroidism is an autoimmune or iatrogenic condition, meaning it can just happen out of the blue as well, as in the doctors might not know why it's happening. But the lacrimal gland may not be the only pathogenic mechanism behind dry eye disease in patients with thyroid eye disorders. So it's been found that these several cells, lacrimal gland acinar epithelial cells, conjunctival and corneal epithelial cells, express thyroid hormone receptors. So again, we think of thyroid hormone as affecting our metabolism and things like that, but we happen to have receptors in our ocular tissues for these as well. And the levels of the ocular surface vitamin D and vitamin D receptors have been reported to be reduced in dry eye disease patients. So I just wanted to point out that this is actually myself as the patient. So I did have, as you can see from these results, what we call the thyroid stimulating hormone, or TSH, was in the very high area here. So I believe, this can happen post-pregnancy and things like that. Your thyroid hormones can be affected. And my vitamin D was also very low. So these other systemic conditions can be affecting dry eye as well. So it's something that, can be treated and assessed if people know what to look for and then draw the association. So, we often have our doctor looking at blood tests, but then no one looking at dry eye all in the same breath. So it's important for someone to draw the dots. So putting knowledge into action. So we should educate on our annual eye check to our patients, and we should insist or encourage them to get their annual comprehensive general health check as well. And, during the consultations, we should provide primary eye care, do very thorough history taking, invest in equipment, and develop a very strong referral network. So whether they're patients that are on borderline and you want to refer them to further ophthalmological care or even general practitioner care, and also to have that network that aware of you as well as the eye care practitioner, that you can handle or look at the eye health side of things. I would encourage you also to connect with each family's health custodian, I'd like to call it, to ensure continuity of care. So often this is the mums in the household or the dads, but these are the people who have control and who are responsible especially for the elderly, and we're able to make sure that they come back for their eye checks and explain, the very importance of why they're getting the eye check and the seriousness of their condition, and how often they need to be screened. And also you can use this opportunity, some of the facts and figures that you've learned today to demonstrate your wide knowledge on general health. The conversations you have with your patients can be a way to differentiate yourself. So this actually brings me to point out that you're no longer just in the optical industry, you're in the wellness industry as well. And with new technologies, we can have a very different conversation with our patient. We may not be comfortable talking about all of these topics yet. As I mentioned at the start, at least if you know for yourself what you want for your long-term, lifelong, healthy vision, and also your loved ones. But the more you learn about this, the more confident you'll be able to speak to your patients about preventative care, and they'll see you in a different light as someone who can bring different knowledge and useful preventative care to them. So I'm just going to wrap up by reminding us that, we covered all the different conditions that patients may not have ideal, healthy, lifelong vision, and welcome you to join us for our next webinar on the 23rd of June. We'll actually be looking at the other circle in our triangle at the start, which is really about looking and feeling good as well in our eyes. Today we covered glaucoma, AMD, and dry eye. So this is my email address if you do want to be in contact with me, and I will just ask if there are any questions from the audience.
Thank you so much, Dr. Shirley, for that wonderful, insights on probably the three most important eye conditions and diseases which you are seeing in the recent past. I think that's really important, and thank you for sharing us with all the opportunities and available options which we can discuss with our patients now. Just that probably sometimes they are not even aware of, looking at things in a more holistic way. So thank you so much for sharing that with us today.
Of course. Thank you.
See, the one of the question, Dr. Shirley, came in is what would be the unique strategy of discussing these options with the patient? Do you kind of bring it in the conversation while you are doing your management, or while you're assessing them during the history, or is it a bit of both, or any thoughts of sharing with the patient?
Sure. So it does start from the history taking. So potentially if they are at risk, if they're having certain conditions, systemic or family history. But it's at the stage when you talk about, even towards the end of the consultation, where you're again suggesting that they come back in 6 months or whatever it is. Because if you say come back in 6 months, they may or may not come back, depending on how they feel. But if you can say to them, glaucoma is the leading cause of irreversible blindness in the world, meaning you can't get your vision back once it's lost. 80 million people in the world have glaucoma, and you have the beginning signs of it. And unfortunately, fortunately, but unfortunately, your pressure is actually normal, so we can't actually lower your eye pressure anymore, in which case the only thing we can do is check you again in 6 months. So you have to explain exactly what you need to do for that patient, and so they really understand, why you're being so emphatic. And use research, so it's not just coming across like, oh, I just want you to come back every 6 months, but using some statistics and research in what you're saying.
That's right. Yeah. And I think nowadays we do understand that the patients are more learned than they were 5-10 years back. They already have done some research, and they have come to you. So I think backing them up with evidence, and I think you did mention a lot about evidence, and you were sharing a lot of research papers, which we can bring that up while having a conversation with the patient. I think one more question which just came in directly to me was, is there any strategy in terms of discussing? Do you kind of use demonstrations, or you kind of give them the papers to read, the research papers, or you kind of show them videos? And what do you think is the most effective way, in your opinion, I think?
So in my experience, sharing stories and cases is actually the most effective way, because people remember a story. So you can say, I had a patient just like you, or it's someone close to me. It could be, my father is taking these medications now, and he's experienced these symptoms. And so, you're on the cusp right now. If you've just started taking your, hypertension medication, because once you're on, it's very hard to get off, very, very hard, because your body's rebalanced to that. So you can discuss with them about, are there other lifestyle changes you could make? Did you know that this can also affect your eyes as well? Sometimes it's the compliance that's the hardest thing for patients. So sometimes if you can give them a real reason, like this could contribute to your, macular degeneration, you might not be able to see, this might be enough impetus for them to start taking it seriously. So sometimes you could be the one practitioner to get through when it comes to explaining to the patient.
Right. Yeah. So I think with that, we have covered the questions which came to me directly on the chat. So thank you so much, Dr. Shirley. The session 1 is up on the YouTube. So if those who would like to rewatch, or somebody who has not watched it yet, it is up on the YouTube. And this session will also be up on our YouTube channel in a couple of weeks. So you could watch it before we invite you to join us for our third session, which is planned on the 23rd of June. So thank you so much, everyone, for joining us. Thank you, Dr. Shirley, for joining us again on this Sunday evening, late Sunday evening, I would say, at our end. So thank you so much for spending this time with us.
Of course. Thank you, everyone. Thank you, Fakhruddin.
Most welcome. We do have other session planned over the next weekend. Until then, take care, be safe, and I hope to see you during the next session. Bye-bye.
Bye-bye.
Bye, Dr. Shirley. Take care.
You too. Bye-bye.
Bye.